We're going to have a debate on neurologic recovery after early versus delayed surgical decompression for acute spinal cord injury. And so we're going to start with Dr. Kenneth Crandall, who's going to present a case to us, and then we're going to have Dr. Fehlings and Dr. Bydon debate the pro and con of early surgery. So starting with Dr. Crandall. But you guys get off soon.
So good. I mean, I think that this is a fitting time to talk about this, given what we just saw. And it's funny because when I was preparing this presentation, one of my cranial colleagues came into my office and he said, "Haven't you guys figured this out yet? Haven't you been talking about it for years?" And we have been talking about it for a long period of time, but I think it's clear that there's no clear answer. None of my disclosures are relevant. So again, we're talking about whether or not there's the timing of surgery for acute traumatic spinal cord injury makes a difference when it comes to neurological outcome, and what are the advantages and disadvantages of both. And our debaters are Dr. Fehlings and Dr. Bydon, who are going to take the pro and con of early surgery. So guidelines for the management of these patients have been published, but controversies still exist. Okay, so what is the classification for and how do you manage these patients medically? Do you use things like steroids, et cetera? Do you perform a closed reduction? Does it need surgery in the first place? When do you do the surgery? What kind of surgery do you do? Do you use a lumbar drain to look at perfusion pressures? And as Dr. Arabi just talked about, do you perform an expansile duroplasty? And the focus of this debate, of course, is when do you perform the surgery? Do you do it immediately, as was just discussed? Do you wait until the next morning? Do you do it within 12 hours, within 24 hours, within 36 hours? And then what is even the definition of early surgery versus late surgery? So a case presentation. So there's a 45-year-old male falls off a ladder, GCS7T with a unilateral fixed dilated pupil, and this is their head CT. And I don't think that there's any debate in this case that this patient needs to be taken to the operating room emergently. But now if you have the same patient, falls off a ladder, their injury is at 10 a.m. in a rural area, they're taken to a small outside hospital where they're diagnosed with a fracture. They need to be transferred to a higher level of care, and by the time they arrive at your hospital, it's now 6 p.m. This is their exam, and they're in Asia 27C, so they're incomplete. They have a C6-7 fracture dislocation. These are their facet joints. And this is the MRI scan showing that there's active compression of the spinal cord. And this MRI was completed at 8 p.m. And you could make the argument, maybe this patient should have been reduced before they went to MRI. Maybe they should be reduced now. Maybe reduction was tried and was unsuccessful. But now it's 8 p.m. at night, so it's 10 hours after the injury. It's a young patient with an incomplete injury. You're already at home. The team that's in the OR is the night team, who's maybe not as experienced with dealing with spine trauma. And you need to make the decision as to whether or not this patient goes to the OR now. Do you take them within 12 hours, which is also right now because we're already 10 hours, and it's probably going to take a couple hours to get into the operating room? Do you wait until the next morning? Do you do it within 24 hours, 36 hours, or later? So now I'll turn it over to our debaters.
Thank you, Ken. Well, if we get my slides up. So I was actually, when I was asking kind of what case we would be discussing, I actually thought we'd be talking about an older patient with central cord syndrome. And respectfully, I'm not sure there's going to be too much debate here for the 45-year-old with a cervical fracture dislocation with an Asia C injury, but I'll be interested to see what my esteemed colleague, Professor Bydon, has to say here. So I'm going to basically present the argument that time is spine. No relevant disclosures, and I want to tip my hat to Mo Bydon, for whom I have enormous respect. So look, here's the case. It's 45, fall from a height, C6 Asia C cervical injury, severe incomplete injury, C7 burst fracture with bilateral facet subluxation. Arrives 8 hours after injury, and there's often is a bit of a time a lag, and that's sometimes an issue even here in North America. The MRI is complete at 8 p.m. Blood pressure is not mentioned. I think that's obviously an important issue to consider. So basically, I think that time is urgent. I think that hemodynamic optimization, I would consider the use of steroids and riluzole in this patient. I would actually get the OR organized right when the patient had come in while the MRI is being done. And basically, the patient will go to the OR from MRI. And I think 8 p.m. in the evening is logistically straightforward, I think, in most places. And I would do this for a front-back surgery. I actually would not try a closed reduction on this case because of the imaging. I would do an anterior corpectomy, an anterior reduction, fix it from the front, and then flip over and do a posterior decompression and fusion. And I like the use of intraoperative ultrasound. And in my hands, duroplasty is rarely required in that setting. So I'm going to talk about the rationale for early surgical intervention. There are new guidelines that are going to be coming out, which I'll briefly summarize, and I'll give you some conclusions, take-home messages. So there's a strong basic science rationale for early surgery, and the idea here really comes from the constellation of the primary mechanical injury, for which we can't really do anything about, but trying to attenuate the impact of the secondary injury. And the cord is compressed. You've got an unstable spinal column. This exacerbates secondary injury mechanisms. And there's actually robust preclinical data. This is an elegant meta-analysis across almost 80 studies from small animals to large animals. And the effect size with early surgical intervention actually mirrors what we see clinically. It's about a 35% improvement in outcome. So this was the seminal study from the Spine Trauma Study Group. Bydon was involved with this. So this is the Staskus study in over 300 patients with cervical injuries. And at the time we were doing this, there was quite a bit of controversy around early versus late. The median time in Staskus was 14 hours, and we decided that 24 hours was a reasonable time based on biology and logistics. But there's nothing magic about 24 hours. And we found that in patients who underwent early surgical intervention, the odds ratio of having a significant improvement, so 2 or more Asia grade change, was 3-fold higher. So it's a pretty large effect size. So based on this, in a small number of confirmatory studies, we issued the first guidelines in 2017. So for the first time, there was a recommendation for early surgical intervention. But as you can see, based on the grade criteria, the recommendations had to be couched somewhat because there was really only one reasonably high quality study. So I personally took this as a significant challenge, and we followed this up with this paper that was published in The Lancet. This was in over 1,000 patients with individual patient meta-analysis. And these are the two of the figures. So on the left, this is a dose-response relationship between Asia motor scores and timing. The red line is 24 hours, and there's a dose-response relationship, which you can see it doesn't plateau out at 24 hours, but clearly there is a linear relationship here. When you see a dose-response relationship in biology and medicine, you need to pay attention to this. On the right side, this histogram shows the clustering of the improvements in Asia motor scores within the first 24 hours. So based on this and 17 other confirmatory studies, there are new guidelines that are coming out. These are in press, and they'll be coming out in the next few weeks. So basically, these are the meta-analyses. In the 2017 guidelines, we are unable to do a quantitative meta-analysis. We now are able to do this. The top forest plots show that there's about a 5-point Asia motor improvement with early surgical intervention within 24 hours. The bottom two plots at 6 months and 12 months outcomes show that there's a 3-fold higher odds ratio of improvements in outcomes. So basically validating Staskus. The bottom scale is a logarithmic scale. So these are quite large changes. So now we have a strong recommendation, and the sentence is pretty short and sweet. Surgical decompression for acute traumatic spinal cord injury is to be completed within 24 hours after injury when medically feasible. And the medically feasible part means that we're dealing with some patients that are quite frail. And it's still, you need to have the physician input in terms of what's going to be safe to do. So what about ultra-early surgery? So look, it makes biological sense. There's emerging literature support. So this is Sanjay's paper, and it makes sense. But I think we probably need stronger evidence. And certainly I think that, this work showing the dose-response relationship adds to this. Now, this paper came out in the last few months, and this has been widely misquoted as showing that there's no role for early surgical intervention. It's absolutely incorrect. So the SkyPalm study looked at ultra-early surgery versus later surgery, and most of the patients actually underwent surgical intervention within 24 hours because of the shifting landscape. And the unadjusted analysis actually just missed showing significance for the ultra-early group at 0.06. The challenge was that there were significant baseline differences between the ultra-early and the later groups that they could not accommodate. But basically the bottom line here is that there does seem to be a signal suggesting an effect of ultra-early surgery. This is Bydon's work that's also been misquoted. So Bydon did show that the extent of decompression matters, and I think it does matter. But we actually included Bydon's work in our meta-analysis, suggesting that there was actually favorable results for early surgical interventions. So take-home messages. So time is spine, surgical decompression for spinal cord injury, all levels within 24 hours makes sense. There's nothing magic about the 24-hour cutoff. I think time is spine, timing matters. In this young person without medical comorbidities, I think getting this person to the OR as early as possible makes sense, and especially in light of the fact that this person has an incomplete cervical spinal cord injury. Thank you.
Thanks, everyone. And thanks very much, Dr. Fehlings. It's an honor to be up here with Mike. I have great respect for his work. This is an area where we have a philosophical disagreement, and I will present my case related to that. We just heard in the prior discussion several surgeons stand up and express concern over the notion that these things have to be done within a certain period of time. Otherwise, there's a negative impact. And there's a reason that people are saying that practicing surgeons are saying that. So, the guidelines is exactly as Mike had said. The initial guidelines presented low quality of evidence and weak strength of recommendations. All the studies around this are observational studies. And, we're all practicing surgeons in this room. Who would wait a week? I mean, that case that we saw, I would take it to the OR, no problem. Now, if someone like that, though, is sicker, is older, and the question is, does the decision to wait result in the worst outcome? So, young, healthy patient comes in, no issues. Who would take them to surgery? Everybody would raise their hand, right? Let's change that a little bit. Let's flip it to someone who's got an LVAD. Let's flip it to someone who's older. Let's flip it to someone who's on Coumadin. Who would then hesitate? So then, we're all making these decisions in our practices. Then the observational study comes in and pools the analysis and says, oh, look, the guy you, the surgeon, chose to wait on did worse. Of course they did worse. Of course they did worse. I chose to wait for a reason. And I chose to take the other one early for a reason. So the evidence is low, the quality of the evidence, the recommendation remains weak. This is an area that's really important because it comes down to medical legal. It comes down to a few basic philosophies. If you agree that within 24 hours people do better, then you have to agree that within 12 hours people do better, because there's no magic to 24 hours, right? And if you agree within 12 hours they do better, then within 2 hours they're going to do even better. So, and we'll get to that, because it doesn't say that's a never-ending game, and the data doesn't say that. I'm not saying that if we do an RCT we won't find that. But I'm saying in the absence of an RCT, we cannot recommend that, because those recommendations have a consequence. So, the literature, here's a study looking at 721 patients, 335 underwent early, 386 underwent what would be defined as late surgery, and was found in this study that the type A injuries don't benefit from early surgery. Maybe the type B and C do. And that's what you'll find in these studies, these cohorts that don't benefit, these cohorts that maybe do. And that's how it works whenever you're looking at p-values, right? Here's here's a systemic review that we did, my group, looking at neurological recovery rates between those who underwent surgery within 24 hours and more than 24 hours after a traumatic spinal cord injury. 36 studies, 4,380 patients, and time to surgery was reported within 24 hours versus later than 24 hours in 2,373 of these cases. And you can see there the meta-analysis. There's a few studies that showed, again, all observational, there's a few studies that showed benefit. but the vast majority did not show benefit. And that's where we land. At thousands of patients, you don't see a significant difference. Neurological improvement rates did not improve significantly depending on time to surgery in the cervical or in the thoracic subgroups. No significant differences, within 8 hours. So why not 8 hours? If 12 hours is better, then 8 hours should be better. So again, within 8 hours versus more than 8 hours, again, no significant difference. Within 48 hours, no significant difference. And remember, 24 hours shouldn't be magical. It should keep going, right? So then it should be ordinal, meaning the first patient we take to the OR should do a lot better than the last patient we take to the OR in that setting. And we'll talk about that in one moment. Here's non-traumatic SCI. Now, in non-traumatic SCI, we found 16 studies looking at 398 patients. In that, though, the problem is 24 hours was not always utilized. And so many of those studies were within 72 hours or outside of 72 hours. And again, when we looked at that, we found no significant difference to surgery. We chose 72 hours because that's where the studies led us. We found no significant difference when it comes to time. And I do want to show you a little bit in terms of the pooled evidence. Again, pooling low-quality evidence does not yield high-quality evidence, right? And so that's an important concept for us all to agree on. So at Johns Hopkins, Zia, Ali, myself, we looked at cauda equina. And this was a similar discussion. You got to go right away. You got to go right away. And that confuses things more than any other. A cauda equina situation is a problem of peripheral nerves. You're not talking about the spinal cord there. You're talking about a collection of nerves. How many people would see someone with a carpal tunnel and emergently take them to surgery? And if I don't take you now, it's an issue. So now we're talking about a problem with peripheral nerves. And by the way, it has to be done. And look at the on paper. Look at the on paper that established 48 hours for cauda equina. And you'll see a lot of problems in it. We looked ordinally, categorically, and continuously at time. And we found that it did not make a difference. When you have p-values, eventually, if you put 20 categories up, one of them will be statistically significant. That's the rule of the p-value, right? That's 0.05. And so eventually, if you create enough categories, you're going to find something. But so what does make a difference? I mean, look, take someone to OR as early as feasible. Who of us in this room would leave someone, in distress and just say, I'm just going to watch it, time doesn't matter. So what did make a difference? And you're going to know this from your own experience in cauda equina. You know what we found? Take someone to surgery. Guess what? Their pain's going to get better. But their function, some patients improve with function, but for the most part, their function is what it is, meaning the greatest predictor of their post-op function is their pre-op function. And you know this. When you operate on someone with cauda equina, the leg pain doctor, the leg pain's so bad. Do their surgery, that leg pain will get better. Okay, great, you got them out of pain. Does the bladder come back? Not really. In some percentage, yes, but it's not related to time. And then, I want to show you finally, when we look at our colleagues in the cranial space, time is brain. All of you guys either have stroke centers near you or you work at stroke centers. Time is brain, time is brain. They're not talking about hours. They're talking about minutes, 30 minutes. By the time this patient came and the injury was at 10 a.m., okay, take him at 8 p.m. or take him at 12 noon the next day. It will not make a huge difference unless I see an RCT that says otherwise. It will, and frankly, we need a group of them in very high quality. We're talking minutes. And the brain is not all eloquent, by the way. The brain has many non-eloquent areas where the spine is highly eloquent. So in the brain, most of which is non-eloquent, it's minutes, but in the spine, it's 24 hours. Is there any logic to that? So again, time is brain, time is spine. We're talking minutes. By the time you get to hours, time does not make a significant difference. That's my belief, unless I see intracontrovertible evidence otherwise. Thank you.
So I don't even need slides to have this conversation. Had it enough times, and I think both speakers, did a great job of presenting, passionate perspectives. I think obviously I think that there's unfortunately so much nihilism in spinal cord injury, even in Ken's presentation, right? What did he say? This is an incomplete patient. And I would push back and I would say, why does it matter? Right? Like why do we still talk about complete versus incomplete? The little small retrospective study that Michael cited, that we did on ultra early surgery, we showed that of our ASIA A complete patients, 89% of those improved to a better ASIA grade. So, I would argue that we should take this complete incomplete label and throw it in the trash with some of the other archaic terminology that we used in the past. Obviously I have a bias, right? So Mo knows which way I'm going to swing on this, but Mo, I will tell you, I'm going to grant your wish to a certain extent. We're going to actually do a prospective multi-center trial on ultra early surgery and spinal cord injury, with Anthony and Praveen and a few other folks who are in this room. So you'll get your answer. It won't be randomized though, but hopefully you'll be willing to accept it. And so, yeah, I would crown Dr. Fehlings the winner on this one.